everyone. Today's presentation is on will SARS CoV 2 become endemic in human population? Influenza viruses, respiratory syncytial virus, rhinovirus, and coronaviruses are endemic in human population due to their ability to mainly produce repeat infections, that is, they can produce infection after infection. Since the emergence of SARS CoV 2, a critical concern has been whether humans will experience reinfections with this pathogen, which might enable it to become endemic. SARS CoV 2, after getting into the body, produces two primarily responses which may prevent a future infection. The first is the presence of memory T cells, the second is the presence of memory B cells. Primarily, these memory B cells, they stay in the blood and they produce antibodies in a subsequent infection, thereby preventing a reinfection. However, for many viruses, a number of processes affect this normal immune response which may prevent reinfection. These are insufficient adaptive immune response, waning of the immune response, and immune escape. These can undermine and circumvent the sterilizing characteristics of the immunity and allow subsequent reinfections. In SARS CoV 2, despite encouraging results from the experimental vaccination of primates, it remains unclear whether these antibodies that are produced are sufficient to provide long-term effective protection or if other adaptive immune components are present and functional. Here we can see that the immune response is quite heterogeneous, especially in SARS CoV 2. If the patient is having a asymptomatic response to SARS CoV 2, there is a high likelihood that they keep on shedding the virus for a longer period of time, which means that probably the immune response that is generated after an asymptomatic infection isn't adequate. Here also we can see here that in the acute phase, both the symptomatic and the asymptomatic patients develop almost similar number of immunoglobulins, but the level of immunoglobulin significantly decreases in the asymptomatic patients in the later stages. The immunity response which can happen resulting in reinfection are the waning of immunity. It is the initial adaptive immune response is robust and protective but dissipates over the time. So even though the patient gets a severe infection or gets a adequate immunity, this immunity doesn't stay for long and the antibodies and the other immune mediators are dissipating over time, resulting in a reinfection. Immune escape is a consequence of antigenic drift that enables reinfection through evasion of the adaptive protection. These are mutations in the sites against which the antibodies are produced, so resulting in non-identification of the site for antibody action and resulting in recurrent infections. The time scale of waning immunity and immune escape differ from pathogen, and for SARS CoV 2 it is yet to be determined. Now, if we look into the longitudinal evaluation, the decline in antibody response to SARS CoV 2, this is a paper which was published, and here we can see that the immune responses decreases significantly after 75 days, and it almost becomes same as what was previously. Now, we have had many cases of reinfections. This is one such case study which was published in Lancet. Here a genomic evidence for reinfection was given. Here the patient was initially infected in April 18th and later on developed another infection on June 5th. Both of the time the patient had RT-PCR positive and both the strains had different genomic characteristics, which means that there is a possibility that we can get infected with two different strains of SARS CoV 2. Naturally acquired infections with the four endemic coronaviruses indicate that reinfection with the same coronavirus can occur within 1 year. Sequential infections with influenza virus strains is seen usually less than 2 years. Similarly, with RSV, 1 year has been seen as the time when reinfection have been documented. By contrast, more pathogenic viruses, all these three viruses which we discussed previously, that is the coronavirus that causes common cold, influenza, and RSV, these do not produce very significant pathogenic response. But more pathogenic viruses which produce more systemic effects tend to produce a long lasting immune response. Longitudinal immune profile of SARS survivors, which was in 2002, showed a stronger immune response with neutralizing antibody which persisted up to 2 to 5 years. Here we have seen that subsequent infections and reinfections with influenza tends to be of lesser severity. This is similar things have been found with repeated infections with coronaviruses, the endemic coronaviruses. Here we see the subsequent infections are less severe. While in viruses like dengue, subsequent infections can be of increased severity. This is because of the antibody dependent enhancement in the transmission and the persistence of the virus and causing a more severe infection. These effects are not yet known how the subsequent infection of SARS-CoV-2 will be. But in most cases that we have seen till now, there is a very heterogeneous response. Some people are getting admitted with more severe response, while some are getting a more milder form of the disease. Now, for SARS-CoV-2, should reinfection prove commonplace, barring a highly effective vaccine, most of the world's population will become endemic. The typical timescale at which the individuals experience reinfection and seasonal differences in transmissibility will determine the pattern of this endemicity. Now, we have seen that in case of influenza, there is a seasonality in respect to which patients develop influenza infection. Primarily, they develop it during the cold seasons, especially in the temperate climates. This is mainly because of the humidity factor and the fact that most of the people stay indoor at home and usually in holidays. Now, the endemic viruses exhibit a seasonal variation similar to the influenza virus. Consequently, numerous studies have shown to determine whether the conditions such as temperature, sunlight, humidity, ozone, pollution can affect the SARS-CoV-2 transmissibility, but none has been conclusive as of now. These may modulate but may not be enough to preclude the transmission during the first phase, when the immunity in the general population was less. But perhaps as it becomes more seasonal, phase log transmission during winter, especially in temperate regions, could be a norm similar to the influenza virus for SARS-CoV-2. Co-circulating viruses can interfere with one another because they will be competing for the same resources, and the interaction has been studied in various population and even at individual levels. Now, many studies have documented the evidence of negative interference between viruses caused by short-lived protection elicited from the first response. This is mainly because of the interferons, which is regarded as the main mechanism with which the interference manifests. Even though it is short-lived, this effect can be strong enough at population scales and temporarily reduce the prevalence of virus or shift the timing of the circulation of the virus. Now, as we have seen, there is interference between the rhinovirus and the influenza A virus that has been well studied, especially in experimental studies. Here we can see the first picture shows the infection because of influenza, and here you can see that once there is a presence of rhinovirus, the influenza virus is not much infecting, which means that there is an effect of rhinovirus on decreasing subsequent influenza infection. Now, in case of SARS-CoV-2, we have seen some reports of co-infections, especially with influenza A, respiratory syncytial virus, parainfluenza, rhinoviruses, and other coronaviruses. So we don't know yet how they are interacting and how they are affecting. But the increased use of non-pharmacological measures and the possible wider interference could be responsible for the reduced incidence of influenza during this year's winter in South Hemisphere. So to summarize, the endemicity pattern of coronavirus or the SARS-CoV-2 will depend on these four parameters primarily. Firstly, the immunity, whether the immunity will be short-lived or long immunity, How will the patient respond to vaccinations? The next is the interactions, the vaccinations, the non-pharmacological interventions, the drug treatments, how do they impact the virus's transmission? The interaction with other viruses, the presence of influenza, respiratory syncytial virus, or rhinovirus, how will they interact with the SARS-CoV-2 infection? Well, will they increase or will they decrease or will they not affect? We don't yet know right now. The last thing is the seasonality. There is a possibility that, especially in temperate regions, there would be a winter transmission of this particular virus. So since it is very early days, we cannot really predict, but most likely there will be an endemicity, but the pattern of endemicity needs to be seen, especially for SARS-CoV-2. Thank you for your patience and check our website for further information.